Top Med Talk.
Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual Congress of the American Society of Anesthesiologists. I'm Desiree Chappell, your host and co-editor-in-chief of Top Med Talk. I'm joined by my co-editor-in-chief, Mike Grocott. It's been a wonderful meeting so far.
It's been superb. Lots of interesting topics, some really good trials been presented.
Yeah.
Everybody's talking about AI. I have no idea what it all means.
Ongoing conversations they do, evolving over the years. But Mike, one of our favorite things to do is sit down and talk with world authorities and leaders within our space of perioperative medicine and hear about all the different aspects of what we do. We cover things like airway and some hemodynamic management. And one of the things we've started to recently, we haven't spent a ton of time, is talking about patient blood management. I have to tell you, I'm hearing about this all over the place now. Every conference we're going to, we're hearing more and more. So we wanted to get some opinion and hear a little bit more about specific blood management processes and the way we manage this. So we are so privileged to have Dr. Klaus Gorlinger here joining us to talk to us a little bit more about VET. Klaus, thank you so much for joining us.
Yeah, VET is a short form for viscoelastic testing. This assesses the viscoelastic changes of a whole blood sample during clotting, because the beauty of our blood is usually it's liquid and it's flowing, and that's the most important thing.
Right.
If not, we get thrombosis. But if you are harmed, you get whatever, major surgery, you get trauma. Then, of course, if there are holes in the vessel, the blood must change from a fluid to a solid thing to close the hole. And that is assessed in viscoelastic testing. So we assess different phases of coagulation. One is initiation, where it started. Then we have amplification and propagation. So we form a clot, but the clot building should be localized at the site of injury. And finally, after healing of the vessel, it should be resolved. That's what we call fibrolysis. In some situations, we have too early that the clot is destroyed. That's what we're calling hyperthrombolysis. So where the standard coagulation test stops, where the first thrombin is generated, we look at the overall phases and can see what is really happening and what is the best way, if there's bleeding, to stop it.
So that is a fantastic overview, Mike.
And so, Klaus, these are the dynamic tests of
Yep.
clotting. And I did some of this kind of work when I was growing up as a researcher. And we talked about the thromboelastogram then, the TEG, and the viscoelastic testing is the kind of generic term for
Yes, exactly. So viscoelastic has a generic term. It started more or less with thromboelastography. What we are working is thromboelastometry, is a modification, because the original form was very sensitive to vibration. It was only in specialized lab on specific table. Nowadays, we can use it mobile at the point of care, because the other point is time is very important in bleeding. So we need results within 10 to 15 minutes to move from giving everything to a specific therapy.
No, sorry.
What else? So I'm a little bit familiar with this from clinical practice. Am I right to say part of the interpretation is the numbers, but there's also a graphical component? There's an image as well. Is that right?
Yes, you have a combination of the shape of the curve and specific numbers. Usually we use both. Of course, if you integrate it in protocols, you mainly work with the numbers, but it's also important sometimes really to look at the graph to see the dynamic of clotting.
Still look like wine glasses?
Yeah, that's thing which is used because if you have like a champagne fluid, so it's too thin, that usually means, yes, it may start in time, but the clot is not strong enough to close the hole in a vessel, in particular when blood pressure is rising. So if the patient is in shock, blood pressure is low, maybe it's closed the hole, now blood pressure gets up and is washed away. So this is also something important and is useful.
Well, that has been a wonderful overview of this process. Klaus, and I didn't get a chance to ask you, so will you tell us a little bit more about yourself and your work in this space?
Yeah. So I worked mainly in I'm from Germany. It's a little bit different that we like even to move from time to time, even as seniors, to different areas. So I worked a long time in trauma where you have some bleeding. Then I moved to liver transplant. You had also some bleeding, and then to cardiac surgery. So in all the fields where bleeding plays a big role. And the point was, again, to reduce bleeding as much as possible. That's the second pillar of PBM. And that means that you can avoid blood transfusion, and particular unnecessary blood transfusion.
All right. So we talked a little bit about the broad overview. So how has viscoelastic testing really evolved? You talked a little bit about even now having protocols and AI and things like that. But in terms of really usability and having that platform automation.
I mentioned already in the beginning was specialized lab, then I moved to the central lab. But this means also delay in time because you have to bring the blood sample to the lab. Sometimes they give back the results. Within the last 10 years, viscoelastic testing was more or less automated. That means you don't need pipetting anymore. You have usually then a cartridge-based system. You enter it in the device, you put the blood sample inside, even without opening the blood sample, and then it's automatically running the test. So that means you don't have the transportation time anymore, and within about 10 to 12 minutes, you have all the information available you need for a clear decision making. Whether this is just surgical bleeding, then you don't need any coagulation factors, or it's a coagulopathy and exactly what kind of coagulopathy it is.
Yeah, and Mike mentioned previous kind of other ways to do this. What are some key differentiators of viscoelastic testing?
Again, when we compare this to standard lab tests, of course, in a lab, precision is very important. What is disturbing is, for example, blood cells, platelets, leukocytes. But the problem is they're all involved in coagulation. So if you do standard coagulation tests just in plasma, and we learned 10 to 15 years ago that it's not the cascade model, it's a cell-based model of hemostasis, that important parts are missing if you only look at coagulation factors.
Yeah.
This makes sense if you want to look for hemophilia. This makes sense you want to look just for heparin or warfarin, but it doesn't make sense if you look at perioperative bleeding. So we get all the information from whole blood, and we get it much faster than sending a blood sample to the lab.
Yeah, that's great.
And my recollection from earlier was it used to also involve you could do a parallel stream of an activator or a parallel stream with an inhibitor. Is that still
Yeah.
part of the technology?
This is something which also changed. In the beginning, tech was just activation, maybe with and without heparinase. Nowadays, we use a panel of assays, as you also do for standard lab tests. So we look at the extrinsic pathway, we look at the intrinsic pathway. We differentiate because for clot firmness, it's fibrinogen and platelets, the main contributors. But in a bleeding, it's important to know, what do I have to? Is this more fibrinogen or is it more platelets? And then we also look at hyperthrombolysis, and we can also knock out hyperthrombolysis. So it's usually a combination of 2 to 4 tests which we use, and then we can precisely say what is needed in this individual patient.
All right. Well, we're here at the ASA this year, the anesthesiology meeting, and we've heard a lot about trials and different publications for all different things. Talk to us a little bit about the publications out there supporting this and the impact of viscoelastic testing on patients, maybe in specific patient populations.
Yeah, of course. We did in the last 10 years a lot of outcome studies because, again, patient blood management is not about transfusion. It's about improving patients' outcome. So it's, of course, nice if you can reduce transfusion, but the main question is, can we reduce complication or even improve outcome? So last year at the ASA, we presented a poster about a meta-analysis. What does changing from just to transfuse by a goal-direct approach on mortality in cardiac surgery? And it reduces mortality by 47%.
4-7.
That means more or less saving every second life. This is a quite strong outcome, and this is by reducing complications. We know cardiac surgery can result in kidney injury, lung injury, so common infections, and that's all is related also to blood transfusion. If we can avoid blood transfusion, we reduce these complication rates and improve outcome.
Yeah. So one of the things we talk about in patient blood management is how to optimize kind of global blood utilization and enhancing the availability of blood. I mean, we've been in critical shortages here, even in the US, which is a well-resourced country. So how does, in the context of that, VET really lean into help?
Again, it's not the main aim just to reduce transfusion, but I know, latest with COVID, it got more and more challenging to get enough donors. And people are asking, do we need more donors? My point of view is we need less bleeding. So by reducing the need for blood transfusion, we don't need anymore so much allogenic blood products. As an example, for liver transplant, when we started with liver transplant, it was usually you need whatever, 20, 30 units of blood. Now we do 50% without blood transfusion. We talk about severe bleeding when we need 2 units of red blood cells. This is something which saves a lot of blood products. We do it more or less plasma-free, improve outcome, and saving costs.
Well, that's what I was just going to ask too, because we always think about the aim of all the things that we do. We want to improve outcomes for sure. There is always a cost associated, but it sounds like if we're not transfusing people, we're avoiding complications of transfusion, we're not spending the money. There is a true economic advantage to it.
Most people just look at, let's say, product costs. What is the cost for 1 unit of red blood cells? What is the cost? Because, also in the US now more and more factor concentrates like for constant PCG get recognized, approved in Germany since 1966. So I was 6 years old. Anyway, but I think what is much more important is cost for complications. We know if you have to put a patient on dialysis, you have prolonged ventilation at the ICU, which is most of the time the most expensive bed in hospital, or you have nosocomial infection with sepsis, that's cost a lot of money. So by reducing this complication, that's the most cost-saving effect.
All right. Well, Klaus, in closing, a lot of us are interested in getting our hands on this types of technology and assays to be able to really, truly key into what we need for our patients. How can people find out more information and maybe look, you talked about protocols and algorithms and things like that. Where should we go?
Yeah, of course, there are a lot of publications. We are doing actually about 250 publications a year. This is all. They are, of course, review papers which summarize the common knowledge about the topic, and in particular from centers who use it already for a long time. There are established protocols or algorithms. And medical guidelines don't recommend the use of viscoelastic testing. They recommend the implementation of viscoelastic testing guided algorithms. So that means you need a reasonable protocol, and they are published. The point is that, of course, you have to adapt it a little bit to your specific situation. Because again, I'm coming from Germany. We're using factor concentrates since nearly ever. Cryo is not approved anymore since 20 years. So you cannot always one-to-one use the algorithm. You have to adapt it a little bit, and also to adapt to your patient population. But you can use it as a blueprint and just do some modification, and then you don't have to invent the wheel again from the beginning.
Yeah. And Klaus, I'm interested, so the trial data from what you're describing, systematic review, sounds very compelling. Do you have data from implementation into practice, and before and after type studies? What do they look like?
Yeah, we have, of course, randomized trials and, let's say, cohort studies, which most of the time before and after studies. That's actually 95 studies, with including 55,000 patients. So that means, yes, there's a lot available, and it depends on the setting, because some people are just interested in cardiac surgery other than liver transplantation. So that means there are adapted protocols from this kind of studies for specific settings. And then again, you can use this as a start and then maybe modify a little bit, dependent also on the therapeutic interventions, which is available in your country, which is still in the US more cryo, platelets, and fresh frozen plasma. And you don't find it in our protocols more or less anymore. We did the last 1,500 liver transplants, plasma and cryo-free. So that means step by step, you may have to start with a little modified protocols that it works also in the US.
Well, thank you for enlightening us on viscoelastic testing. I know we've touched on it over the years, and just patient blood management, again, is a hot topic in anesthesia right now. So it's great to hear more about it. So thank you so much for joining us.
Yeah, you're welcome.
All right. And thank you for listening to Top Med Talk. You know, you can always find us at topmedtalk.com. We are on your favorite social media platform. We are on your favorite podcatcher. Wherever you do find us, be sure to give us the thumbs up. Be sure to give us, comment, any star rating. We'll take it all. We really appreciate it. It gives us feedback to know what works and what you guys want to hear. So let us know. We do want to thank our sponsors. The American Society of Anesthesiologists have been a major supporter of Top Med Talk each year to bring the knowledge that we gain by talking to wonderful leaders across the world every single year here at Anesthesiology 2025, and we couldn't do it without them. So we want to thank them. We also have our sponsor, Werfen, who keeps Top Med Talk free and open access to the world.
Making the world healthier through the power of conversation.
Cheers.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.